This conference will now be recorded.
Today's topic is tubectomy and vasectomy. What are these procedures? These both are surgical procedures which comes under the heading of sterilization procedures for both female and male. What do you mean by sterilization? Sterilization is a procedure which destroys the procreative function and the effect is usually permanent. What do you mean by procreative function? It is unable to beget a child. That is, if this procedure is done in a female patient, it is a permanent procedure, first one. Second one, it is a procedure which destroys or which prevents the woman to become pregnant after the procedure. This is a permanent sterilization procedure. If it is done in females, we call it as tubectomy. If it done in males, we call it as vasectomy. Coming to the definition once again, it is a procedure which destroys the procreative function, that is becoming a chance of becoming a mother or a father, that is a parent, and the effect is usually permanent. The term sterilization is generally restricted to those cases in which the destruction of reproductive function is the primary purpose of treatment. What are the indications of sterilization? Our first indication of sterilization is population control. How come sterilization will have an effect on a population control? Is when you start doing sterilization procedures or when you encourage the parents or the couple to have a limited family. That is all we know, this government statements of 2 for 2, that is two wife and husband couple, for them only 2 kids are better. When these couples are encouraged to have an procedure like this, so that we can prevent them having the unwanted child, so that the population will be coming under control. The other indications are when you want a family limitation, when the couple themselves want a limited family, that is like I can opt for a limited family, or I can go and ask directly a gynecologist saying that this is my limitation in my family. I want only 2 kids. So I want to have a permanent sterilization procedure. Then in that indications and all, we can ask the couple to undergo a sterilization procedure, that is a vasectomy or tubectomy, or other medical indications such as when the patients are having permanent ill health of the potential mother, that is when the be having a child will show an permanent effect on the mother's health, then it also can be considered for medical indications and allowing the mother to go for a sterilization procedure. Permanent ill health of the potential father also. Any diseases or genetic faults which can be transmissible to the fetus, such as cystic fibrosis and all. That can also be an indication for a sterilization procedure. Previous obstetrical complications and operations or high parity. High parity is your multiparity, that is more than 5, that is gravida 5 and all. Other non-specific methods which cause sterilization are hysterectomies, that is removal of uterus so that the mother can never become pregnant. Bilateral salpingectomy, if the tubes are removed, there will be a little less percent of the mother to become pregnant, because there will not be any connection between the ovum and the sperm. So there will be this is a method of sterilization, and when you remove the ovaries, there will be no chance of having an ovum. These all three are done in non-specific methods in the female partner. All these have an incidental sterilization effect. But the term sterilization is generally restricted to those cases in which the destruction of the reproductive function is the primary purpose of the treatment. Coming to female sterilization by tubal ligation or occlusion. What do you mean by what is the English meaning? I mean, meaning of ligation is to put a knot. Occlusion is to put something so that the passage will not allow the passage, tube will not allow the passage of either sperm or an ovum. Ante tubal ligation ante enti ante రెండుటిని కట్టేయటం so that there will not be a potent passage. Occlusion ante enti ante అడ్డంగా పెట్టడం so that there will not be a passage. Types of tubal ligation or occlusion, that is the puerperal sterilization or the post-abortal, non-puerperal, that is interval sterilization. Puerperal sterilization is a process which is performed in conjunction with the cesarean delivery or soon as the vaginal delivery in the puerperal phase. That type of sterilization is called the puerperal sterilization. Usually when we are doing a cesarean delivery, and if it is second gravida or third gravida, where they have limited, I mean, they are willing to give you a consent for a tubectomy sterilization procedure, we can do a sterilization procedure with the cesarean delivery itself. If the woman, I mean the female partner has underwent an vaginal delivery, but she wants a sterilization procedure, then we can go for a mini lap or lap sterilization procedure, that is the tubectomy. If the procedure of sterilization is done immediately with cesarean delivery or immediately after in the puerperal phase, then it is called puerperal sterilization. The other type of sterilization is interval sterilization. Interval sterilization is which is not related to pregnant. It can be done at any time of I mean any part of the female partner's age. That is, see, they have divided into puerperal sterilization and interval sterilization based on the time it is done. If it is done with the cesarean delivery or immediately after the vaginal delivery, or if it is done with the delivery, then it is called puerperal sterilization. In the puerperal is puerperium period. If it is done irrespective of the delivery, that is like if a female partner has delivered this year, if she wants to have a sterilization procedure and has come to us next year, then that procedure when we do, it is called interval sterilization procedure. The methods of sterilization procedure are abdominal, vaginal and transcervical. Coming to the abdominal, it is laparotomy using a laparoscope, mini laparotomy, or sorry, laparotomy is cutting open the abdomen. Mini laparotomy is helping, the aid will be there. In a laparoscopy, that is during the using the laparoscopic machines, which is mostly usually preferred method in when the patient come for an interval sterilization, because laparoscopic has its advantages such as less time, no very little scar, less pain. Vaginal is through anterior or posterior pouch, that is choldoscopic pouch. They open the POD or anterior pouch, catch hold the tube, do a ligation procedure, or during the transcervical, that is occlusion by chemicals. Timing of sterilization, as we have already told, if it is done with the in a puerperium period, it is called puerperal sterilization. If it is done irrespective of the delivery time, it is called sterilization. This timing of sterilization is when you are doing an interval sterilization procedure. That is, if a woman's situation is she's having a cycle, then when we can do, we can ask her to come any time within 7 days after the start of her menstrual bleeding. that or any time of the menstrual cycle, provided it is reasonably certain that she is not pregnant. That is, if suppose a patient has come to us saying that I have a child some 2 years back, I wanted to have a tubectomy procedure, but my LMP, that is my last menstrual period is 2 months back. Without doing an urine pregnancy test, you cannot even post her for sterilization, because you have, whenever you are doing a sterilization procedure, you need to know the pregnancy status of the patient, because the failure rate of the tubectomy is more. Switching from another method, when the patient is already on OCP, then sterilization can be done at any time, but she can continue the pill until the pack is finished to maintain her regular cycles. Or if she is having an IUCD, then sterilization can be done at any time. But when you are doing a sterilization procedure, remember to remove her IUCD from the uterus. That is, if she doesn't bleed menstrual bleeding, then anytime it is reasonable, before doing a sterilization procedure, go for urine pregnancy test, confirm that she's not pregnant, then plan for tubectomy. Or if she has not done her puerperal sterilization, then when we have to do, then in that scenario, woman in sterilization can be done within 7 days after giving birth. That is, postpartum mini lap tubectomy can be performed. Suppose if she has underwent a section and she has given us a consent saying that I want sterilization, then concurrently we can do a sterilization procedure in the cesarean. If the same woman has underwent a delivery, normal vaginal delivery, but she wanted tubectomy, then in that condition, when we can do within 7 days post delivery. But the best phase to do is 48 to 72 hours after delivery time. Why here comes a question, why we should not do after 7 days? Because then infection chance, failure chance will be more. Then you have to ask her to come after 6 weeks after the childbirth, which is then certain that she is not pregnant, then go for a interval sterilization. Concurrent sterilization or puerperal sterilization is like till 6 weeks post delivery. After that, any time if the woman comes to your OPD for an sterilization procedure, then it is called interval sterilization. If the patient has underwent an MTT, in that scenario, when we have to do, in that scenario, when she's going for a surgical MTT, or then we can go for within 7 days post MTT. If it is a medical abortion, tubectomy should be done only after the next menstrual cycle, because infection rate will be more and failure rate of the tubectomy will be more. If it is a laparoscopic tubal occlusion procedure, can be performed only in MTPs up to 12 weeks of gestation when you are doing an MT. If immediately after miscarriage or after abortion, if there are no complications, within 7 days we can do. That is, if miscarriages, if she had an 5th month, 6th month miscarriages and she is willing for tubectomy, we can do within 7 days, considering it as puerperal phase. After using an emergency contraceptive pills, then we have to go for tubectomy within 7 days after the start of next month menstrual cycle. What are the coming next is the eligibility of providers to perform the sterilization procedure. What are the basic qualifications required for the service provider? That is, which doctor can do an tubectomy, because tubectomy is a government procedure and it is a government surgery where it is legalized, and without the requirements of a service provider, that person qualified service provider has to do. What are the basic qualifications? Those are DGO, MD, MS in OBGY, specialists and other surgical fields, but trained in mini lab. These are the service providers' basic qualifications who can perform a tubectomy. Eligibility criteria for the case selection. We have dealt of eligibility criteria for a doctor. Next comes your case selection. Client should be ever married. When you're doing a procedure, I mean tubectomy, patient should be married. Female age should be between 22 to 49 years. Male age should be between 22 to 60 years. The couple should have at least one child whose age is above 1 year unless the sterilization is medically indicated. When does a medically indicated or these conditions comes on under your when having a child will show a potential ill health of the mother or father, or fear of transmitting family history of diseases such as cystic fibrosis and all. In those conditions you can go for a tubectomy, considering that scenario is a special scenario, indicated scenario. Or clients or their spouses, that is the partners, must not have undergone sterilization in the past, should know the sound state of the mind so as to understand the full implications of sterilization. That is, both the couple has to understand what is the pros, cons, side effects, and long-term complications of the procedure. Then only we can do in that couple. Mentally challenged clients must be certified by a psychiatrist. If a female partner is a mentally challenged, then in that condition she might not understand what is a procedure to be planned to be done on her, or immediate complications, post complications, surgical complications, and long term complications. So in that scenario you need to go under you need to ask for a certification from the psychiatrist for her for her, so that we can do a sterilization procedure. Pre-operative evaluation of the patient. The history should be taken. Her last menstrual cycle have to be noted. Her urine pregnancy test has to be ruled out. Any history of contraceptive used history should be asked for. And if it is there, if she has already discontinued, you need to know when and why she has discontinued. Her medical history has to be noted, whether she has any medical illnesses or any psychiatric illnesses has to be noted. Then coming to the examination, we have to do for a general examination, abdominal examination and pelvic examination, speculum, to rule out any pregnancy and PID. So our main problem is, if it is a pregnancy, we need to postpone the surgery. If it is PID, we need to think of failure rate of tubectomy, and we need to prior go for an antibiotic course. Laboratory examination, which has to be done mandatory before the surgery, is to know her hemoglobin status, to know her urine examination for sugars and albumin. Pregnancy test is compulsory, must. HB of less than 7 should not be accepted for sterilization and refer to higher centers for management. Consent and risk counseling. The consent of the patient is must. In practice, in the case of married couple, it is wise but not essential to obtain the consent of the spouse also. That is, if the couple has come to you and female partner is willing for tubectomy sterilization procedure, but the male partner is not willing. Actually, according to the government, the female partner willingness is only required for a tubectomy surgical procedure, but we need to even counsel the male partner, and it will be wise if you take consent from the spouse also, so that we can avoid unnecessary legal issues. The possibility of the failure of the operation should be dealt before and explained to the couple. Counsel the couple that operation is intended to be permanent and cannot be reversible. And if it is reversible also, very less chance of having a child normally. The existence of alternatives for the surgery, such as vasectomy, has to be explained. That is, male can undergo a simple procedure. Risk of ectopic pregnancies will be more if there is a failure rate of tubectomy. These are the counseling issues and consent issues to be taken before. The others are all risk of surgery, however remote they are, should be explained. All your anesthesia risk and all. No effect on sexual. You have to clearly explain that it will not have any effect on sexual activity, which is most worrying in the male partners. We see in the when the couple come to us for a sterilization procedure, and you have to clearly explain to them that tubectomy will not protect against STDs, that sexually transmitted diseases such as HIV, HPV, and HBsAg and all. Reversal of tubectomy is possible but not sure. So this has to be explained, documented, and consent should be taken. It is wise if you take from the male partner also. These are all the things you have to deal with before posting a patient for procedure. Anesthesia, we go for a local or regional anesthesia in a mini lab. In vaginal route also we go for regional anesthesia. When we want to post for laparoscopic, usually we go for a general anesthesia. Surgical approach. In a mini lab, interval and postpartum. In interval sterilization procedure, we give a 2 to 3 centimeters midline vertical or transverse incision, suprapubic. We cut open the rectus muscle, first sheath, muscle, peritoneum we open. We handheld a retractor from the down into the uterus to lift the tubes in a Trendelenburg position, which gives us a clear exposure of the tubes. And we catch hold of the tubes, bring the fallopian tubes, because we do have a elevator from down, which will be introduced into the uterus and elevate the uterus so that tube will be visible. We catch hold the tubes with the Babcocks, do a ligation procedure. If it is postpartum, we usually go 2 to 3 centimeters subumbilical, vertical, or semicircular incision will be made in the midline. Techniques of sterilization. There are different techniques. How you see, this is a mini lap, and normal vaginal route is through which you open the abdomen. What are these techniques of sterilization is, how do you catch hold a tube, how much of the tube will be cut. Based on the tube, there are different techniques, that is Pomeroy's, modified Pomeroy's, Parkland, and all. We will discuss each one now. Coming to the modified Pomeroy, tube is grasped in the mid portion with the Babcock's. Loop is elevated. It is important to follow the tube distally to its fimbriated end to ensure that fallopian tube is ligated, not the round ligament. Initially, we need to confirm whether you are holding a tube or round ligament, because both look alike. So whenever you catch hold a tube with the Babcock's, you need to go in search of fimbria, whether that fimbria is continuation to the tube loop which you hold it. If it is in continuation, then you hold it up. You can have a assurance that you have catched your fallopian tube. When the fimbria is not attached to the tube which you are which you handheld, then it is not the fallopian tube. It is your round ligament. Base of the loop is ligated with plain one catgut. 2 to 3 centimeters of the ligated loop is resected. This is a diagram which is showing where in the A picture, Babcock's is holding the tube. In B picture, we have made a loop, and we have with a white catgut, plain catgut, we are ligating it. We have ligated the other end also. Then we have put a knot. In E, we have cut the loop. This is modified. The excised tube should be appropriately labeled and sent to the pathology lab for histological documentation that you have removed the tube, not a round ligament. The advantages of modified Pomeroy's is it is simple to perform and highly effective, minimizes the bleeding by compressing and sealing the mesosalpinx before tubal resection. It can be performed abdominally, vaginally, or laparoscopically. The complications are very minimal. In modified Pomeroy's, you remove 2 to 3 centimeters of the tube. Ligated tube will be resected. Coming to Parkland, the next procedure, which is identify an avascular section of the mesosalpinx. A window is created in this region below the tube. with the scissors or hemostat and will elevate the tube with the babcocks. By opening the scissors within the window, it can be stretched in parallel with the tubal limen. Rapidly absorbable, that is chromic or plain catgut sutures are proximal and distal. The segment of the sutures is then excised. This is making a tube from the ligating a tube from the mesosalpinx. Coming to the Madlinus. In Madlinus, a loop of ampullary portion of the tube is elevated and both the segments are held with the hemostat cut, ligated, and material used to ligate over the tube and crush the area. In Madlinus, there will not be any tube excision, but it will be same like your modified palm rice. But here tube will not be excised. So there will be more failure rate in Madliner, that is almost like 7% of tubectomy failure. What do you mean by tubectomy failure rate? Is even after doing a tubectomy procedure, the female partner will become pregnant again. If she becomes pregnant, then it is called failure of tubectomy. The devascularized loop of the tube undergoes aseptic necrosis. This technique is abandoned due to high failure rates. That is almost like 7%. In Irving's method, the tube is divided in the region of ampullary isthmic junction and the ends of the sutures are cut long for traction and for use in the subsequent steps. And the cut end of the using a blunt dissection, a tunnel is made within the substance of the uterine myometrium and the proximal tube is pulled into the chamber and suture. The distal end of the tube is then buried within the substance of broad ligament. Here you cut both the ends. For the proximal end of the tube will be buried in the myometrium, and the distal end will be buried in the broad ligament. This procedure is called Irving's. Uchida is a subserosal injection of saline epinephrine solution is made in the region of tubulary ampullary region. The serosa is then excised with the scissors, exposing the muscle layer of the tube. A segment of the muscular layer is elevated while the serosa is simultaneously stripped back over the proximal and distal ends, and the proximal portion of the muscular tube is ligated, excised, and the proximal ligated segment then drops back beneath the serosa. A pursue string is placed around the distal end and tied. In Uchida's method, we remove the muscular layer of the tube. This is how it is different from the other methods. Next is Aldrich method. Here Aldrich method is the almost like we do a fimbriectomy, where the fimbrial end of the fallopian tube is drawn into the pocket beneath the peritoneum of the broad ligament, and the buried fimbrial end is then securely placed in by several sutures. If when you bury the fimbrial end, it is called Aldrich method. If you cut the fimbrial end, then it is called coronal fimbriectomy. It is defined as a corona because it is described by coronal, where the ligation of the distal ampulla of the tube with the two permanent sutures, and then the division and removal of the infundibulum of the tube is done. These are different types of sterilization procedures. Coming to the laparoscopic sterilization, it is usually done under GA, that is general anesthesia. Pneumoperitoneum should be created with a versus needle. Insufflation of the abdomen should be done preferably with a carbon dioxide gas. Intra-abdominal pressure should not exceed of more than 15 mm of mercury. The uterus and tubes are manipulated to convenient positions by an uterine elevator through the cervix or by a probe from above. A portion of each tube with its inner margin of 1 to 2 centimeters from the cornea of the uterus is coagulated by with diathermy and divided, or clips or rings can be applied. After applying the second ring, systematically inspect the pelvis to verify that both the tubes are occluded or not. You have whether there is no unusual bleeding, or when there is, you need to even check for an visceral injuries. This is the silicone rubber where isthmic portion of the tube is held with a grasping tongue about 3 centimeters from the uterus, and the tube is applied. This is on one more method where hulka or spring clip is applied to the tube. This is one more method. This clip is called fishy clip. The precautions to be taken while applying a fallopian are: draw the tube slowly and smoothly into the sleeve of the laparoscope after proper identification to prevent injury into the mesosalpinx tube. Avoid pulling up or back or lapricator. In such cases, tubectomy should be do not apply rings in the case of thick or edematted or fixed tube because failure rate will be more. In such cases, tubectomy should be avoided and should be done with a laparotomy by a conventional method. This is a clip band. This is an halka clip. This is a fishy clip. Coming to the other methods of tubal occlusion, that is your coagulation methods. During laparoscopy, instead of putting a band clip, you can go for occlusion, that is unipolar coagulation and bipolar coagulation. In a unipolar coagulation, 3 to 5 centimeters of the tube can be destroyed with a single burn. Disadvantages is dermal injuries to other abdominal viscera, capacitive coupling, delayed necrosis, and peritonitis. Bipolar coagulation is current flows from one jaw of the grasper to the other. So advantages of having a bipolar coagulation is more than, doing with a bipolar coagulation is more easy. The other is chemical occlusion. In this, the obstructing the lumen of the tube along their length by liquid non-irritant materials or injecting chemical irritants to produce aseptic endosalpingitis. That is inflammation of salpinxis tube, endo is inside. Chemicals like methyl cyanoacrylate and quinine have been used to destroy the corneal end. Or the other procedure is assure, where it looks like a spring where the device is inserted transcervically via hysteroscope. It is available as a part of disposable system, which includes micro insert of 4 centimeters length and 0.0 mm diameter, delivery system, and a split introducer. Micro insert contains a stainless steel inner coil, nickel titanium alloy outer coil, and a layer of PET fibers. It looks similarly like a spring in your jet pens. Any pen, it looks like a spring. It will be introduced into the through cornea into the ampullary, isthmus region near the cornea. How does it provides? It acts as an sterilization. Is it causes the release of inflammatory and fibrotic response to the PET fibers. These fibers start causing the adhesions in that area, so that it will log. It will cause an occlusion thus preventing the swim up of sperm or ovum travel, prevents the fertilization. When you have put an assure, a HSC must be performed 3 months post incision to assure the complete bilateral tubal occlusion is done or not. Post-operative follow-up instructions. In the case of interval sterilization, she may have intercourse 1 week after the surgery, but whenever she has feels comfortable thereafter. In a case of postpartum sterilization, she may have intercourse 2 weeks after the sterilization. Any complications or miscarriage, she need to immediately come to the hospital. What is the complications? Intraoperative and postoperative. Intraoperative is when you are doing, instead of doing for a, while you are catching hold of a tube, fallopian tube, you can injury the round ligament, or you can directly do a clamp for round ligament instead of fallopian tube. Anesthesia complications, embolisms, uterine perforations, bleeding, injury to the urinary bladder, and vice versa. Coming to the postoperative complications, any wound sepsis, hematoma, intestinal obstructions, ileus, paralytic ileus, tetanus, or failure of the procedure. What do you mean by post-ligation syndrome? Tubal ligation syndrome. It will be your 4 marks or 2 marks question, where it is a perception that menstrual disturbances could result from tubal sterilization. The failure rate is, the instance of failure is less than one pregnancy per 100 women over the first year of after having the sterilization procedure. These are all the female sterilization procedures. Coming to the male sterilization procedures. That is the conventional vasectomy, or the non-scalpel vasectomy. Coming to the conventional vasectomy, 2 or more with 1 incision on the midline. The length of each incision should be not more than 2 centimeters. The mid-scrotal part of vas should be removed. Not more than 1 centimeter in length of the vases should be removed. This is a diagram where it is clearly showing how the vas is ligated and cut. Removal of the excess mass may be subsequent recanalization will be difficult. So here, while you are doing a vasectomy, keep in mind that only 1 centimeter of the vas should only be removed. Ligate at the 2 points about 1.5 centimeters apart using 2-0 silk. Facial interposition is recommended. The skin incision should be closed with non-absorbable sutures after ensuring complete hemostasis. The other procedure is your non-scalpel vasectomy. The basic difference between non-scalpel procedure and the conventional technique is surgical approach into the vas, which is through a small puncture in the scrotum rather than by cut with a scalpel. When you are doing no scalpel vasectomy, here instead of using a blade, you go for an non-scalpel vasectomy scissor, where you puncture it, catch hold your vas, lift it up. In a conventional method, you give an incision on the scrotum, then hold the vas. These are the main differences between both. The advantages is non-scalpel vasectomy is less invasive than conventional. Technique is more easier, causes fewer complications and takes much less time. Non-scalpel vasectomy is to be performed under local anesthesia. Procedure: fixation and the vas is fixed in the midline at the junction of its upper 1/3 and lower 2/3 by wax fixation forceps. The skin of the scrotum is then punctured at that site and vas is delivered out in non-scalpel vasectomy. Only 1 centimeter of length of the vas is removed. Follow-up: he should report to the clinic for semen examination 3 months after the surgery. He has to be clearly explained that barrier contraceptives are to be used for 3 months, because in that time they might have a pregnancy. Vision FP 2020. In 2012, the London Summit on Family Planning was held to bring back the focus of family planning globally. India committed to spend 2 billion by 2020 for family planning program. In 2014, India has renewed its commitment and now promises that it will invest 3 billion by 2020, and the goal is to ensure access to family planning services to 48 million, that is 4.8 crore people, additional women by 2020. What are the goals of Vision Air Family Planning 2020? The goals are increasing access to contraceptives through distribution of contraceptives at doorstep of beneficiaries through community health workers. That is all your condoms, OC pills and all. Ensuring healthy birth spacing by augmenting the focus on spacing methods. What do you mean by spacing method? Is the gap between the two pregnancies. Strengthening the sterilization services through quality service delivery and demand generation. Under the Vision Family Planning 2020, the government has encouraged the districts to ensure the availability of non-scalpel vasectomy services in their facilities on fixed day basis. Family Planning 2020 initiates emphasis on providing mini lab sterilization services in high delivery case load facilities. What are the snapshot of family planning interventions or services? Under this, there will be promotion of spacing methods by IUCDs. There will be door delivery of your all contraceptive devices. Adopting a strategy for having a family planning services even in PHCs and CHCs. Encouraging all the male partners to have a non-scalpel vasectomy. Family planning includes postpartum services such as supply of contraceptives, adolescent reproductive and sexual health services, safe abortions and post-abortion services, pregnancy test kits at even sub-health center level. These are entire sterilization procedures which will be done both in a female and male. Types of procedures, both male and female, and Vision Family Planning 2020, a quick review. That's it. This is a class for today. In this, you might expect a question such as your non-scalpel vasectomy can come for 2 marks or 4 marks. Then you can have a question on mini lab. You can have a question on post-tubal ligation syndrome. These are the questions you can expect for exam. Or you might have simpler questions like what are different techniques of tubectomy, where you need to go for you need to write all the answers of all these different types, such as modified Pomeroy's, Parkland, Irving, Uchida, Kroner's, fimbriectomy and all. These are the questions you might expect from this topic. విన్నారా?
Yes,
హలో,
ma'am.
సరే, అర్థమైందా అసలు టాపిక్?
Yes, ma'am.
ఓకే అమ్మా, బాయ్, థ్యాంక్ యూ.
Thank you, ma'am.